Good evening, everyone. How are you all? All right, so welcome to First Aid AMC MCQ free 2-week sessions again. Now, as we have already given you enough information about the free 2-week session, this is our last session on those free sessions. So I hope that you guys got enough idea about how our course is going to be, and also get to know about each and every other mentors as well. So we took classes for a lot of topics with you, almost most of the important things that you need to know before you can enroll a course. And that should be more than enough to show that if we can satisfy what you actually want from a course or not. Now, the 2-week session started on 2nd of May. We started with, even before that, we had our trial class with psychiatry trial session. And then we had a question solve tips and tricks. After that, we also had 2 cardiology class for theory. And then you got back-to-back 2 recent question solve class, one with Dr. Rabia and another with Dr. Arus. And then you are here today for the last session on 2 weeks free class, and that will be your cardiology question solve. So as we told you during this free session, that our course is designed in that way that you learn the theory and also the questions side by side. So we do theory-based question solvation like this today. So we finish cardiology, and then after that we do question solve. And then again, you get the recent question solved with some other mentors and sometimes also by me. So that's how the course is going to be. It is most likely that you get 3 classes per week, sometimes maybe even 4 classes per week, based on how many question solved class that you are getting. It's a 5-month session, which means there is a lot of classes that's going to be with you. And I can assure you that if you can finish the whole topics that we are doing with you, there is nothing else that you actually need for this preparation. And the portal that we offer you as part of the course, that has everything that you need for the exam. You get the mock exams, the exams which will help you to understand that if you are ready for the exam or not. That will also help you to understand how actually the exam is going to be. So it's a combination of everything that a particular candidate might need for this exam preparation. Okay, so let's start with our class today. And at the end, we will go through the course detail as well. The course admission will be stopped after a week. So still, if some of you are here who wanted to join, but just you waited because you wanted to see the 2 weeks free session, this is the time you reach us and also send either a message to my inbox or send an email to us. So that will be the way to go from now onwards. The orientation class will happen on Tuesday. So I would strongly recommend, if you want to join before that, because in orientation class, we actually go through the portal, we go through each and every aspect of this exam. So it will be a very important class for you to join. Okay, so let's start with the cardiology question solve, and then we can have a question answer discussion at the end. So this is your first question. You have got a 17-year-old male running a race and suddenly collapsed on the floor. Luckily, someone was there and performed CPR, as patient did not have a palpable pulse, and resuscitated him. Upon arrival to the emergency department, it is revealed that his father died at the age of 28. So sudden cardiac death in the family. He is now alert, asymptomatic. ECG was non-eventful. He is anxious to go home. What would you do next? So your main task is that what's your next investigation? Always look on the task that what actually they want you to think of, that is it the most appropriate management or is the initial management. So what they actually ask, that also matters a lot. So what do you think this patient diagnosis is? So syncopal attack in a 17-year-old who has a family history of sudden cardiac death. That gives you the diagnosis, right? So it's likely to be a HOCM. It could be also congenital prolonged QT syndrome that also can have this kind of similar history of early cardiac death. So let's say it's HOCM. In that case, what are you going to do? Send him home and arrange an outpatient consult with a cardiologist, send him home without doing anything, admit and refer for cardiology team consultation, outpatient echo or stress echo. Now, the best thing from this option is that admit the patient and have a cardiologist consultation. Because you already did a ECG, next step will be done by the cardiologist anyway. So that will be your first thing that you would rather do in here. Okay, so C will be your answer here. Obviously, you would not just send him home because the risk is here. If you send him home, this patient can also have a sudden cardiac death. So you need to do a full assessment while the patient is admitted in the hospital. Next question. A young athlete presents with history of sudden syncope and dyspnea. ECG shows left ventricular hypertrophy, and patient's father had a sudden death at a very young age. What is your initial treatment? So initial treatment is important. This is a young athletic patient, had a syncopal attack with left ventricular hypertrophy. So what will be your initial treatment? Verapamil, septal myomectomy, defibrillator, low molecular weight heparin or adenosine. Again, the diagnosis remains the same, HOCM. For HOCM, what's our main treatment or initial treatment? So remember what we have discussed in HOCM, because there is muscle hypertrophy, right? The diastolic function will be reduced in this patient. So because the muscle become very much hypertrophied, it contracts a lot, so it doesn't get enough time for the heart to get filled with blood. So the diastolic function will be low, and it causes diastolic heart failure as well. So for diastolic heart failure, what is our usual choice of treatment? Something which can reduce the heart rate, like beta blocker, rate limiting calcium channel blocker, that will be our choice. Okay, so if we come back, so in this case, verapamil is a rate limiting calcium channel blocker. We don't have any beta blocker in the option, so this will be our option to choose. Good. Have a look to the next question. A young girl, 15-year-old, collapsed at exercise. Her father had a HOCM. After ECG and echo, you found no abnormality. What is your next step in this patient? So there is a family history of HOCM, but this young girl who is 15-year-old also had a sudden collapse. But ECG echo is normal. What else you want to do? Do you want to just send the patient home because ECG echo is normal? Or you want to do a Holter, stress echo, repeat echo again, or repeat echo after 3 years? Remember, I told you that in those situations, if you strongly suspect that the patient might have a HOCM, then you have to do a stress echocardiogram. Because sometimes during a stress echo, the echo might show that this patient has got HOCM as well. What I'm showing you is that how many ways are there for a particular question to appear in your exam. So that's why we always say that you have to have a very good knowledge on theory. Otherwise, if you just memorize a particular answer of a question, that's never going to help you in the exam. So always make sure you have a good knowledge on that particular topic, from the symptom, what are the sign or physical examination finding, what is your initial investigation, what's your confirmatory investigation, what's your initial treatment, and what's your best treatment. That should be your way of learning each topic that come in the exam. Now you have got a 9-year-old male who was running and playing football, suddenly collapsed on the floor. 9-year-old. Upon arrival to the ED, it is revealed that his father died 28. He is now alert, asymptomatic. What would you do next? Alter, stress echo, repeat echo after 3 years, just do a echo or ECG. We will always start with the ECG first. Even in our questions, we can see that they have done ECG and echo, right? First is ECG. If you go back, you will see ECG shows LVH. So always we start with ECG in this situation. Even though ECG might not show anything, still we will have to do it. Cool. So you did get how the HOCM questions can come in the exam. Now, moving on to some different ones. So a 16-year-old male who presents to you with an ejection systolic murmur in the second left intercostal space. Which of the following is likely to be the diagnosis? Now, this is a tricky one, and that's how the murmur questions come in exam. A lot of murmur questions come. If you can remember what we have discussed in that class, then the murmur questions are not very hard to answer. Now, this is a patient who obviously has ASD, right? Because that means every option has atrial septal defect. So this patient has got ASD anyway. Now, other question is that what causes this ejection systolic murmur in the left second intercostal space? Now, the tricky part is to understand the basic of it. If you don't understand the basic, you will always get lost. So remember that we discussed this is the left. Let's say this is second intercostal space. That's third, fourth, and fifth. Now we know from here that if this is the heart, we know that the aortic stenosis murmur, if this is the thing, right? So if this is your aorta, so aortic stenosis murmur usually best heard on the right second intercostal space, because you can see that it originates from the left heart, but it actually have this curve, and that's why it's best heard on the right second intercostal space. But your patient having it on the left intercostal space, so it's not the aortic stenosis, right? So cross that. Mitral stenosis murmur usually should be heard on the fifth intercostal space, and it's not an ejection systolic murmur. What's the mitral stenosis murmur, guys? MDM, mid diastolic murmur. So again, you can remove that. Coming to aortic regurgitation. Aortic regurgitation, do you remember what's the murmur of aortic regurgitation? Yes, early diastolic murmur, right? So again, that's not going with the ejection murmur. So you can, even if you don't know the answer properly, if you just do the exclusion wise answer, like I also say sometimes that if you don't know the answer, then start doing the exclusion. With exclusion, you will actually wind up with the correct answer anyway. So this is your correct answer, ASD with pulmonary hypertension. What's the reason of it? Let me show you. So that's your pulmonary artery, right? So what happened in this case that if we divide our heart like this. So this is your right atrium, that's your left atrium. In case of ASD, atrial septal defect, there will be an abnormal connection here. So what will happen? There is a abnormal connection or a septal defect. So blood from the left heart, because left heart has more pressure and more blood. So blood will flow from the high pressure area to the low pressure area. So from the left atrium towards the right atrium. From right atrium, blood will move to the right ventricle, and more blood will go to the pulmonary artery. And when there is more pressure of blood on the pulmonary artery, that will cause pulmonary hypertension. So ASD patient can get complicated with pulmonary hypertension in this way. It's not the murmur of pulmonary hypertension, but it's the murmur of ASD that you are getting in here. So coming to the atrial septal defect. Atrial septal defect is the second most common cause of congenital valvular heart disease, or you can say congenital heart disease. So in atrial septal defect, the main finding in the physical exam is ejection systolic murmur in the left mid-upper sternal border. So usually you get a ejection systolic murmur in this case. Okay. The findings in atrial septal defect, patient or the children usually will have features of heart failure like dyspnea, shortness of breath on exercise or playing outside, failure to thrive, those kind of stuffs. How to confirm the diagnosis? Echocardiogram. If we come to the VSD, VSD is the most common congenital heart lesion. VSD, it causes a pansystolic murmur in the left lower sternal border. So the murmur is a little bit different in VSD. Okay, so VSD pansystolic murmur in the lower sternal border. It's also on the left side. ASD is a ejection systolic murmur on the left mid to upper sternal border. All right, so please remember this too because it comes in exam. Again, when we do the pediatrics, this ASD, VSD, and also pediatric cardiology will be discussed in detail. Clear everyone that how we choose C in here? One of you asked that in which condition defibrillator used. Usually we use defibrillator in patient who has ventricular tachycardia, which is pulseless VT, or if someone has got ventricular fibrillation. That's usually the only time we use defibrillator. Move on. A young guy, while playing cricket, suddenly had syncopal attack without any convulsive feature. Soon he spontaneously recovered and started fielding, continue playing rest of the game. What was the cause? So sudden syncopal attack, and then he spontaneously recovered. There was no post-syncopal confusion. So when a syncope happens suddenly, and the recovery is also very sudden, what's the likely cause of it? The likely cause of it is cardiac syncope, because cardiac syncope happens very suddenly without any prodromal feature. And then also patient regain their consciousness very quickly without any confusion or drowsiness afterwards. Whereas if it is a vasovagal syncope, patient will lose consciousness gradually. They always have a prodromal symptoms like they have lightheadedness, dizziness, blurring of vision. That means they know that they're going to fall, and then they fall, they lose consciousness and gradually regain their consciousness as well. So gradual is vasovagal syncope. Cardiac syncope happens very quickly. Okay. Epilepsy, obviously, in that case, you would get some finding like patient had a tongue bite, patient lost control of bowel or bladder, or patient has a jerky movement of their body. So it's unlikely. Postural hypotension, unlikely for a young guy. And always postural hypertension has some postural effect. That means when they change their position from a sitting to a standing position, that's the time when they feel dizzy, or sometimes even they can have a fall. And the neurogenic syncope, patient will have some neurological deficit or some neurological abnormality in your history. So if you look over here, that cardiogenic syncope, the patient drops suddenly, regains consciousness in seconds. Neurogenic also can happen suddenly, and it usually come back in minutes. Like it takes a little bit of more time. Metabolic, patient goes gradually, comes back gradually. Okay. I would always suggest that if you have got a patient who had a syncopal attack very suddenly and regained consciousness very suddenly as well, in that case, it's cardiogenic syncope. In cardiogenic syncopal attack, it's usually you will start with ECG. You will also do a Holter monitor to find out any kind of arrhythmia, and then you can do a echocardiogram as well. In case of vasovagal syncope, usually they always give you a clue that patient was standing for a long time, or patient was running in a hot sunny weather, or maybe patient was having some kind of exertion. But it's not just that. The symptom should match. Like a patient who was playing cricket or football outside, that can sound like patient is exerting himself. But the idea is that in vasovagal syncope, patient will have a prodromal symptom, and then gradually they will lose their consciousness, and then again gradual regain of consciousness as well. That has to be there to say it's a vasovagal. Great. Move on to the next one. A 45-year-old man presents to the ED with left-sided chest pain radiating to left arm and jaw. There is no ECG changes. Troponin is negative 4 hours since the onset of chest pain. He has been on sildenafil for erectile dysfunction, metformin for diabetes, ramipril for hypertension. What would be the most appropriate next treatment for this patient? Now, if a middle-aged patient having like a chest pain which radiates to the left arm and jaw, there is no ECG or troponin change after 4 hours. Can you rule out the possibility of myocardial infarction straight away? No, you can't, because the 4 hour is not enough for the ECG or troponin change to happen. So in this patient, obviously you will start treating the patient as if it's a myocardial infarction. You will need to keep the patient in the hospital for observation, and then you will do a repeat ECG and troponin every 3 to 4 hourly to see that if there is any change. At least you need 2 to 3 troponin and ECG to be normal before you send the patient home. Just because in 4 hours there is no change, it doesn't mean that it cannot be a non-ST elevated MI. Now, for this patient, nitrate, heparin, morphine, beta blocker, paracetamol. Paracetamol has nothing to do with cardiac pain, so forget about this one. Now, among these 4, what will you do? We never start beta blocker in an acute attack. Always remember that. Beta blocker is not given initially. Okay? Only time we would go for beta blocker is that when you have treated the patient and then you discharge the patient, during discharge, beta blocker will be added. Nitrate is contraindicated because this patient was on sildenafil for erectile dysfunction. You cannot give nitrate to a patient who is on sildenafil because it will cause a profound hypotension. The best idea in here would be morphine. Heparin is still, we don't need to do it because still there is no evidence of non-ST elevated MI in this patient. Okay, even there is no change, like there is no ST depression or anything. So if there is no change at all and troponin is not elevated, we don't need to start with heparin straight away. we can wait for the troponin to be elevated and then we can give them heparin. For such case, the morphine would be the ideal choice. Okay, but obviously if aspirin was in the option, that would be the best option to choose, but that's not in the option. So in exam, sometimes the most appropriate option will not be there. So in that time, you have to search that what is the next best option that I have got. Clear, everyone? Great. A 72-year-old male presented with severe chest pain radiating to his back. On cardiac exam, you notice diastolic murmur. Chest X-ray shows widening of the mediastinum. ECG given, and ECG is this. Now we haven't discussed ECG in the class, so but just have a look on here that what we have got. This patient, basically, if we look in V1, so this is the isoelectric line. And idea is that this ST wave should be on the isoelectric line. So this is ST depression here. Same in here, ST depression, ST depression. V4 having ST elevation. V5 having ST elevation. V6 ST elevation. Lead 1 and AVL. 1 is fine, but AVL having ST depression. But look over here. This is what you can see, that this patient has got lead 2, 3 AVF, massive ST elevation. This is likely to be an inferior MI. Little bit of lateral also there, but mostly inferior MI. That's the likely case. Okay. So in such an inferior myocardial infarction, why we call it inferior? Because lead 2, 3 AVF is the inferior leads. And anterior MI means V1 to V6. Lead 1 and AVL is the high lateral leads. So if someone has got ST elevation in V1 to V6 and also a lead 1 and AVL, then we would call it as an anterolateral myocardial infarction. We will discuss the ECG in detail in our ECG class. Let's not go into that much detail. The next is chest X-ray, where it's shown that patient having a widening of the mediastinum. You can see how wide it is. What do you think the diagnosis is in this patient? This is an aortic dissection complicated by acute myocardial infarction. Very complicated scenario, right? So in this situation, what are you going to do? Give altiplase, which will cause thrombolytics, aspirin, intravenous morphine. They are asking for the most appropriate management. Give morphine beta blocker and arrange for transesophageal echo. Refer the patient to cardiology clinic. Consider urgent MRI of the cervical and thoracic spine. Obviously, this is not the case. Can we give altiplase in this patient because this patient having myocardial infarction? No, it is contraindicated to give fibrinolytic in a patient who has got aortic dissection because it will just make the patient to bleed more. Aspirin, morphine, well, we can give it, but that's not the best management. We will obviously refer the patient to cardiology clinic. But what's the most important thing at the moment you need to do? At the moment, you give a morphine that will lower down the pain. Beta blocker, remember that beta blocker is the first line management for aortic dissection, especially type B aortic dissection, and arrange for a transesophageal echocardiogram because transesophageal echocardiogram can confirm aortic dissection. So that will be your best option to choose out of all these 5. We will try not to choose this, referring the patient to the cardiologist, referring this. So that's usually our least likely answer to choose in the exam. Usually they always ask something that we need to do first before we send them to the cardiology or something like that. But again, if there is no other option, then yes, referring the patient will be our choice, but that will be our second option to choose. So if you look over here, this patient, this is how we say that patient can have type A and type B aortic dissection. This is your left subclavian artery. Any dissection after the left subclavian artery is called type B. And anything proximal to it is type A dissection. Okay, so type A dissection will need urgent surgical management. Type B, you can start with conservative management with lowering down the blood pressure first. Lower down the blood pressure by IV labetalol or beta blocker. Have a look on this med bullet a little bit about this aortic dissection. So we discussed about what is Stanford A and what is Stanford B. Aortic dissection is common in patients with Marfan syndrome or bicuspid aortic valve patient. Most of the time dissection happens for hypertensive patients. We know that patient with aortic dissection can have unequal blood pressure in their both arms and also absence of pulse. Now the result, the murmur that we have got in this patient, because sometimes when the aortic dissection happen, it can also affect the aortic valve. So when aortic valve is affected, then it can cause this aortic regurgitation murmur, which is that early diastolic murmur. So it's a very commonly, sometimes when the dissection happens, the aortic valve can also get involved, and that causes this murmur. In here, they say that CT angiogram of the chest and transesophageal echocardiogram. Now, in between these two, transesophageal echocardiogram will be our best investigation. If that is not in the option, then CT angiogram will be our choice. Great. Moving on, an elderly man with multiple falls during the day, especially in the morning after waking up. ECG found left ventricular hypertrophy and multiple ventricular ectopics. Orthostatic hypotension was also noted. How will you investigate further? What do you think, guys? What do you want to do? So you want to do repeat measurement of blood pressure in supine and prone position, 24-hour Holter, electrolyte level, echocardiogram. So this patient having multiple fall, especially in the morning after waking up, can it be a case of postural hypotension? Because when the patient is changing position, then the patient having the fall? Yes, obviously, because you have got orthostatic hypotension already in the question, right? To find out the orthostatic hypotension, what we normally do is that we check the patient's blood pressure on sitting position, and then we check it in a standing position. If there is a drop of blood pressure of systolic blood pressure more than 20 and diastolic blood pressure more than 10, that's the time we can say it's a orthostatic or postural hypotension. Can a single reading confirm the diagnosis? No. You need at least 2 to 3 readings showing the same postural drop before you can make this diagnosis. So if even in the question, if you get that patient orthostatic hypotension was noted, you have to do a repeat measurement of blood pressure in sitting and standing position. But the trick in here is that they say they want to do it in supine and prone position. That doesn't do any postural change, right? So that's why this repeat measurement of BP will not work. But the same question, if the option was repeat measurement of blood pressure in a standing and lying position or a standing and sitting position, then you would choose that first. Okay, but now let's say they have already confirmed the diagnosis of postural hypertension. It's not just that, you have also found patient having multiple ventricular ectopic with LVH. In such case, there is a likely chance that some might also cause this fall in this patient. To confirm that diagnosis, you need a 24-hour Holter monitor, and Holter monitor can actually confirm those arrhythmia and how frequently patient is getting that. Because if the patient getting frequent multiple ventricular ectopic, conduction delay, okay, or even sometimes you can find out patient getting into heart block, that's the time you can think that maybe the fall is also related to some cardiac cause. So anytime if you think the patient having some ECG changes, even there is no ECG changes, but patient having multiple fall, the first thing we do is to check the postural drop. If postural drop is ruled out, the next step is to do a Holter monitor to find out any ectopic bit or any kind of conduction delay or heart block that's happening. We could do serum electrolyte if there was an option. There was something written that patient having vomiting lately, patient having like urinary tract infection and going to the toilet more than usual, or patient having sweating a lot. So something, if the question says that might let you think that patient might have a hyponatremia or something like that, then you can choose serum electrolyte. So this is actually the chart for syncopal attack. So loss of consciousness is what we call as syncope. It can be sudden, and in case of sudden syncopal attack, we think about cardiogenic cause or neurogenic cause. If it is a gradual, then likely to be something metabolic like hypoglycemia, so those kind of stuff. Regaining consciousness. If regaining consciousness is also sudden, it's likely cardiac. In that case, you do cardiac examination, you do ECG, echocardiogram, you do it as you go and according to the patient's symptom. If it is a gradual regaining of consciousness, in that case, depending on what you get, if the patient having any kind of seizure or epilepsy, then you have to go for a CT scan of the head or MRI of the brain and a EEG. It depends on the finding always. Okay, so think about it. If it is a sudden syncope and sudden regaining consciousness, it's cardiac. Sudden syncope, gradual onset of gradual regaining of consciousness could be seizure or epilepsy. We always remember that if a patient having gradual loss of consciousness had a prodromal symptom and then gradually regain consciousness, that's likely to be vasovagal. You can see that routinely get a CT scan of the head, ECG, cardiac enzyme, echocardiogram. We also do this 24-hour Holter monitor for this patient. So just remember one thing, that if a patient having a syncope and you have ruled out postural hypotension, then the next best step is to do you can do a ECG, like a baseline ECG, and baseline ECG showing some finding like ventricular ectopic, LVH, or even there is no finding, then the next step is to go for a 24-hour Holter monitor. Clear for everyone? Next question. A young patient has been getting multiple lightheadedness and dizziness. His clinical features are normal. Chest X-ray, ECG normal. Holter monitor shows ventricular ectopics. What will you do next? Reassure the patient, exercise tolerance test, dobutamine induced echo, or plain echocardiogram. So you have got a young patient who is having lightheadedness, dizziness. Patient chest X-ray, ECG normal. Clinical features are normal. Holter showing just ventricular ectopic. Have a look to this guideline from John Mutta. Most of the patient who has ventricular ectopics or premature ventricular complex, they are asymptomatic. Symptom can happen at rest in bed at night. Drugs that can cause this include digoxin and sympathomimetics. Look for evidence of ISD, mitral valve prolapse, thyrotoxicosis, and ventricular failure. If symptomatic, our patient is symptomatic, but otherwise well, with a normal chest X-ray and a normal ECG, reassure the patient. So that's your answer. Have a look. Patient is symptomatic, but otherwise well. Chest X-ray, ECG normal. Reassure the patient. That's it. Because most of the time it will not, the patient doesn't need any medication for it unless it becomes really severe. Then only we can do further investigation. We can do an echocardiogram after that. And then if echo shows that patient doesn't have any structural heart defect, in that situation, we can give the patient some kind of beta blockers, especially atenolol, metoprolol. So you can see that drug therapy never comments drug without performing an echocardiogram. This will help to guide the choice of agent. Class 1 agent can make arrhythmia worse, even life-threatening if there is a reduced ventricular function. So the thing is that before you start these beta blockers or anything, do a echocardiogram. But if a patient it's a young patient, having symptom, but everything else is normal, okay? In that situation, you can just reassure the patient that there is nothing you need to do at the moment. Young patient, we will try our best not to give any cardiac medication. Like a 16-year-old, if you start them with metoprolol, that doesn't look that good. Most of the time, this lightheadedness, dizziness will get better. Next, you have got a scenario. So time to time in exam, the side effect of medication will come, and drug interaction is a very commonly asked question in the exam. So you always need to know the common side effect of the common medications. So a scenario of multiple drug for a patient who is using ramipril, which is a ACE inhibitor, amlodipine, calcium channel blocker, hydrochlorothiazide, which is a diuretics, celecoxib, which is a NSAID, asking about which combination making muscle weakness without tenderness. Ramipril hydrochlorothiazide, amiloride ramipril, celecoxib hydrochlorothiazide. So what do you think that causes muscle weakness without tenderness? So first of all, let's see that muscle weakness can be caused by hypo and hyperkalemia, right? And we know that this medication has something to do with potassium. So ramipril, ACE inhibitor, can increase potassium, whereas hydrochlorothiazide can decrease potassium. So this will counteract each other and there will be no problem. Celecoxib, NSAID sometimes can increase potassium and hydrochlorothiazide decrease potassium. So again, counteract each other. So what else we have got? Amiloride, which causes increased potassium. Ramipril, which also cause increased potassium. So you have got two medication, which is increasing potassium. So this patient actually can get hyperkalemia. Both hypo and hyperkalemia can cause muscle weakness. So just don't think that hypokalemia will always do muscle weakness. Hyper also can do the same. Okay, so be very careful in this kind of drug interaction cases. Clear, everyone? I can see a lot of you thought about A and C, not a lot of you thought about B. So amiloride increases potassium, ramipril increases potassium. So you're giving the patient both medication which increase potassium. That causes hyperkalemia, which can cause muscle weakness. ECG of an adult presented with chest pain, cardiac enzymes, and first ECG normal. BP 120/70. After 8 hours of observation, his blood pressure goes down to 89/50. So patient is in shock. ECG showing supraventricular tachycardia with heart rate of 150. What would you do? Now I know that we haven't discussed about the palpitation chapter because we are going to do it during our ECG session. Now, let's give you a basic idea about supraventricular tachycardia management. That will help in our ECG class as well. So supraventricular tachycardia, patient will present to you with palpitation and heart rate will be elevated, as you can see over here. In case of SVT management, first thing that you look that if the patient is stable or unstable. If the patient is stable, in that situation, you can try some conservative approach first. So what are the conservative approach for SVT? You do any kind of Valsalva maneuver. So Valsalva maneuver, you can also do immersion of the face in a cool water that will also do the same vagal nerve stimulation. You can do carotid sinus massage. So anything which can stimulate the vagal nerve. Okay, so that's your conservative approach. If you have tried that, still patient is in SVT, the next step will be medical management. The medical management starts with IV adenosine. So you can start the patient with IV adenosine. If that doesn't help, again you can repeat the adenosine after a few minutes. Even after adenosine, if patient is still in SVT, the last option will be DC cardioversion. That means a shock. If adenosine is not in the option, then you can also choose any of those calcium channel blocker or beta blocker. But for SVT, this is the best. Okay. Now, if a patient having unstable SVT, in that case, you directly go for DC cardioversion. Okay. And what is unstable means? Unstable means if patient's blood pressure is less than 90/60, if patient having severe shortness of breath and having confusion or loss of consciousness. Those are the unstable patient. Okay. So in this case, what you are going to do, so it's a SVT patient who is in shock. This is the unstable SVT. You have to go for synchronized or DC cardioversion. All good, everyone? Did you guys understand it? Good. Next, a patient on digoxin, bisoprolol, and thiazide diuretics. Long-term history of hypertension and congestive cardiac failure with AF. Stopped taking medication for the last 3 weeks while on vacation. Now patient presents to you with edema up to his knees and a raised JVP of 4 centimeter, but with clear chest sound. Now, chest sound clear means still there is no fluid accumulation in the lung. We usually say that we have to add furosemide or diuretics, especially if a patient has got pulmonary edema. Most of the patient who has got CCF, they will have some form of ankle edema. They will have raised JVP, but the most important thing that will lead you to start furosemide straight away, that is pulmonary edema. In this patient, there is clear chest sound. So it's not mandatory that you start furosemide straight away. BP is little bit high, pulse irregular, that's because of AF. What would you do as an initial management of this patient? Commence furosemide, commence spironolactone, commence metoprolol, commence digoxin bisoprolol, recommence all medication. In this case, we will recommence all medication because this patient was already on all the medication that he needs. That means thiazide diuretics will help with this edema that he has got. Bisoprolol will help. Bisoprolol can be started because it is still not a decompensated heart failure. Decompensated means especially if a patient starts to get difficulty breathing and having sign of pulmonary edema. And digoxin can be started as well. Okay, so the best approach in this case is recommence all medication. Now, if the question told you that patient having bibasilar crepitation on the lung, that means patient having a pulmonary edema. In an active pulmonary edema patient, you have to start them with furosemide first. And you can't start them with bisoprolol or any beta blocker because it will just make it worse. So in those situations, your answer should be furosemide first, lower down the volume in the lung or the fluid accumulation in the lung, and then recommence all medication. Okay, so two questions come, they just change the scenario in this way. Next, a ECG has been given showing M spike QRS complex in all leads. Also, like let's say there is M spike everywhere. M spike means like this. Usually we get it in bundle branch block patients and irregular. So it can be AF. Heart rate is 150. Scenario given, the patient having hypertension. Patient is taking only atorvastatin, no chest pain. So what will be your next management for this patient? So let's say what we have got is a patient who has hypertension, taking cholesterol lowering medication. So likely that he has hypercholesterolemia, coming to you with a irregular pulse and heart rate is elevated. So basically it is atrial fibrillation with a high heart rate or tachycardia. So what will you do next? Metoprolol, apixaban, warfarin, verapamil. Now coming to the management of AF, same like SVT, it depends if the patient is stable or unstable. In case of a stable AF, you can start with rate control medication. So how to do the rate control? So either you start with beta blocker or calcium channel blocker. The first line will be beta blocker like metoprolol, atenolol, those medication, or that's not available, then CCVs. If with this medication rate is not controlled, then you can go for your next approach with the rhythm control. Rhythm control, we do it by anti-arrhythmic medication, which is your amiodarone or sotalol or flecainide. So these are usually the anti-arrhythmic drug we can give a try. Even after this, is still patient in AF, then you go for DC cardioversion. In case of unstable AF, first option is DC cardioversion. Also, if they ask you, is there any curative treatment? Yes, sometimes we can do a radio frequency ablation of this, and that can cure the problem. Okay, so that's the AF management. AF management is never finished without finding out the Chats-Vasc score of giving them anticoagulants. Now that will be discussed in our ECG class, that how to do this Chats-Vasc scoring and which patient with AF will need anticoagulant and which patient will not need. Now for this patient, what are you going to choose? It's a stable patient, so we will choose beta blocker like metoprolol. That will be our first thing to do. Great. A middle-aged man with a known hypertension started feeling dizziness and he feels his heart is racing. So palpitation, dizziness. It occurred after running. There was also travel history few days ago. Very important history. He is on irbesartan and hydrochlorothiazide and well-controlled hypertension. No diabetes, BP is good, no postural change. What is the most appropriate next investigation for this patient? First thing is, what's your diagnosis? A middle-aged patient who had a travel history recently, now feeling dizzy, having palpitation. What do you think? Yes, likely chance DVT complicated by pulmonary embolism. Travel history is a very important finding. So long travel history followed by patient having palpitation, difficulty breathing, feeling dizziness, our most likely cause is pulmonary embolism. For a patient who you suspect to have pulmonary embolism, your first, initial, next, most appropriate, everything is CTPA. All right? So sometimes there are other things that we do like VQS scan, D-dimer. So those will come into your respiratory class. But just remember until now that most important investigation in these patients is CTPA, because we don't need to do a whole range of other investigation in this kind of life-threatening problem and then do a CTPA. CTPA is your initial investigation in this situation. You have got everything that you need to suspect pulmonary embolism. If you think that this is pulmonary embolism, you do a CTPA straight away. Okay? Keep this thought in your head. In case of our respiratory class, this will be discussed in detail. There is a lot to learn from pulmonary embolism. Okay, so that's it. So let's take a 10-minute break now. And after that, we will do some more. Any questions so far, guys? All right. So let's take a 10-minute break. Thank you all. All right, everyone, let's start again. This is your next question. So this is a tricky one. Now, one of you asked that in case of SVT, in unstable patient, why don't we use adenosine? Because it has a rapid action. That's right, it has a rapid action, but adenosine can also lower down the blood pressure. So if you give adenosine in a patient who is already in shock, that will cause more damage. So that's the reason why we can't give it. Okay, so 60-year-old male, 10 years history of hypertension, feeling dizzy and lightheaded from this morning when he was doing exercise. Smoke 20 cigarettes a day, so he is a smoker. Drink 2 to 3 glasses of wine most of the night. Blood pressure normal. So that's on sitting and 120/70 on lying. So it's not postural drop. Currently on these medications, symptoms lasted for about 2 hours. ECG given showing SVT with a heart rate of 150 per minute. What is the cause of his presentation? Dehydration, ischemic heart disease, hypertension, alcoholic cardiomyopathy. 2 to 3 glasses of wine, it's not very high amount. So it cannot cause alcoholic cardiomyopathy. Now tell me about these 3 options. What do you think a 60-year-old who was doing exercise and felt dizzy? So that should at least give you some idea that during exercise, someone got dizzy. On the top of that, they have got some risk factor, hypertension, smoker, right? So, and also the age. In a patient who is high risk like this, I would not think about dehydration causing the SVT or dehydration causing these symptoms. I would always think that this is ischemic heart disease that's causing it. Okay? If it was a 30-year-old male, then I would think that it's a dehydration causing the SVT because that could be the case. But this is a 60-year-old we're talking about who has hypertension, smoking. That's more than enough that he is a high-risk patient of ISD. So, and also any exertional dyspnea or any exertional symptom in a patient who has high risk like this, I would always think about ischemic heart disease first, rather than thinking just dehydration causing it. So the age matters a lot in the exam. Same case, it becomes 30-year-old or 35-year-old, I would think that it's a dehydration caused it. Okay, so the age matters a lot. You have got a patient and the patient actually came with a chest pain for 15 minutes, which was relieved by rest. ECG shows bradycardia with a prolonged QT, troponin normal, pulse normal, regular, blood pressure normal. What to do next? So a patient came to you with a chest pain for 15 minutes, relieved by rest, ECG normal, ECG bradycardia and prolonged QT, and all other things are normal. Repeat troponin, echo, coronary angiogram, repeat ECG. What do you want to do? Always remember, any chest pain which lasts more than 10 minutes can be it can be a non-ST elevated MI. It can be ST elevated MI. Now, it's also important to know that when was this chest pain? Okay, so in exam, they will give you more detailed question, obviously. And the most important thing that they already did a troponin. If they did not think that this could be a MI, they would not do troponin, right? That should be in your head, that why troponin was done in the first place. Because if it is just a stable angina, why I am doing a troponin? The reason is that we are looking for a possibility of a MI. So in such situation, the next step is always you need to do a repeat ECG in 3 to 4 hours time. you need to do a repeat troponin in 3 to 4 hours time. Once those are normal, then only you can discharge the patient. Okay, just because in the ECG you have got bradycardia and prolonged QT doesn't mean that that was the cause of chest pain, because bradycardia doesn't cause chest pain. Prolonged QT doesn't cause chest pain. Okay, so, and again, in case of inferior MI, you can get bradycardia, right? So a lot of things can happen. So the first thing that you have to do in such cases is to do a repeat ECG in 3 to 4 hours, and then do a repeat troponin at the same time. If those are normal, then you can send the patient home. Is this understandable for everyone? So the next is repeat ECG. A woman who is on multiple drugs, one of them is digoxin, presented with central abdominal pain and tenderness. Her pulse is irregular. Apart from a CT angiogram, what is the most appropriate next investigation? Now, this will be a very tricky question for you. Think a patient who has got atrial fibrillation coming to you. Let's say this is a 60-year-old female coming to you with a central abdominal pain and tenderness. What should be your diagnosis at that time? Very good, Dr. Shayan Parvez. Acute mesenteric ischemia. Because acute mesenteric ischemia, it can be a complication of AF patient. AF patient tends to form clot, right? And if a clot gets dislodged, then that emboli can block the superior mesenteric artery, causing this acute severe central abdominal pain. In this case, patient will also have periumbilical tenderness, they can have nausea, vomiting, and also they can get parectal bleeding. So your next, you can say that your most appropriate investigation is to do a CT angiogram, and that can confirm the diagnosis, and the patient needs to be taken to the operation theater as early as possible. What else we can do in a CT angiogram patient? Sorry, in a mesenteric ischemia patient. Mesenteric ischemia means the part of the gut, which is like part of the gut artery, which is blocked, that part is not getting blood supply. Like if this is the mesenteric artery, there is a clot over here. So there is no blood supply in this part. So this part is actually not getting enough oxygen. Okay, in this situation, in here, there will be lactic acidosis. So increased lactate will be one of the finding in any kind of ischemia. So we say that if you really want to find out if this patient has got any kind of ischemia, then just do a serum lactate, and that will obviously be high in this patient. Okay. You can go through this Medscape, and you can see that this is the central abdominal pain, which gradually gets worse. Profuse vomiting, watery or bloody diarrhea can be there. Next. So you have got a 23-year-old man coming for follow-up. His bilateral arm blood pressure is between 140 to 160 by 100 to 110. So it's a little bit on the higher side on several occasions. So it's a hypertension in a 23-year-old. Occasional headaches, rest of the physical exam and urine analysis is normal. Heart rate normal. Patient has got mild LVAs that might be related to hypertension. Beta blocker, thiazide, captopril was used, and blood pressure is still 150 by 100. You have used 3 medication. What is resistant hypertension, guys? Resistant hypertension means that if you use 2 antihypertensive on a patient, maximum dose of 2, and still blood pressure is not controlled, that's resistant hypertension. Resistant hypertension in a patient who is young like this, we always should look for something secondary. So there has to be something secondary cause of hypertension in this patient. And what is the most common cause? Renal artery stenosis. So resistant hypertension in a young patient, we should always rule out the possibility of renal artery stenosis. So what we do in this case, duplex ultrasound of renal arteries, because that can confirm or even rule out the possibility of renal artery stenosis. Okay? All other investigations, they actually would not help with anything. So we are mainly looking for any secondary cause of hypertension. So now there are two kinds of things. Renal artery stenosis can be found in young patient, can be found in elderly patient. Usually middle-aged or elderly patient, they get it because of atherosclerosis. Young patient, they get it because of fibromuscular dysplasia. So any patient who has got renal artery stenosis, usually we should say that if a patient does not have a family history of high blood pressure, cannot be successfully treated with at least 3 or more different type of blood pressure medication. And in this case, we talked about elderly patient who is more than 50. So elderly more than 50, no family history of blood pressure, and you have tried 3 medication, still not coming down, we should think about renal artery stenosis. Same with the younger patient, you have tried 3 medication, nothing happened, we should go for Doppler duplex ultrasound of renal arteries. Next, an elderly patient taking digoxin and hydrochlorothiazide presents with palpitation, ECG given, what is the cause of his problem? Now, you remember, like we talked about digoxin, which can cause almost every kind of arrhythmia. We haven't discussed this with you in the class, but remember one thing, that any patient who has digoxin, that can cause digoxin toxicity, even if the level of digoxin is normal. Now, this patient has some sign of digoxin toxicity. We call this thing reverse tick sign. So it's a ST depression, but it looks like a reverse tick. So if you get a reverse tick sign of ST depression in most of the lead, like you'll be able to find out in lead 1, lead AVL, there's a little bit in lead 2, not much in 2, 3 AVF, little bit in here, in here. So most of the lead you will get a ST depression, looks like a reverse tick sign. That is more than enough to say that digoxin has caused some toxicity in this patient. So what will you do? You think it is a digoxin toxicity, and most likely that you will need to stop this medication for the patient. Okay. Next, a patient on many medication, metoprolol, so beta blocker, digoxin, furosemide, ECG given, patient complains nausea, vomiting, abdominal pain. Digoxin level is normal. What to do? Same type of question. Now have a look on the ECG. We haven't discussed ECG, so it will be very tricky for you. Look at the lead 2. You will find out that this is what we call as prolonged PR interval. This is your P wave, right? And then this is your QRS complex. This starts from, this is the P and this R. So that's what we call as PR interval. In a normal patient, PR interval is between 3 to 5 small square. In this patient, you can see this is 5 small square. This is at least 3 to 4. So at least in here, you have got 8 to 9 small square. If someone has got a prolonged PR like this, that is what we call as first degree heart block. So I told you that digoxin can cause almost any kind of arrhythmia. So heart block is also one of the digoxin toxicity feature. So this is a first degree heart block in a patient who is on digoxin. The problem is that the level is normal. Just because level is normal doesn't mean that toxicity cannot happen. You have got the most common side effect of digoxin toxicity, which is nausea, vomiting, and abdominal pain. So in this case, you have to stop this digoxin anyway. There is nothing that you can do except you stop digoxin and then see that if the patient is getting better. Still not getting better, then also there is antidote like digibind that can be used. Yes, we should check the potassium level because digoxin toxicity can cause like potassium abnormality, but that's not the first thing that we would do. In this situation, the first thing is always to stop the medication which is causing the problem, and then we do the more evaluation. Okay. ECG of WPW syndrome, heart rate is very high, systolic pressure is still okay. What is the management? Now, WPW syndrome is another kind of arrhythmia. What happens in WPW syndrome? You must have a basic idea about how the heart electrical impulse work, right? So this is the SA node and that's the AV node. Every kind of electrical impulse originates from the SA node and then it goes to the AV node, and through the AV node, through your Purkinje fibers, bundle of his, it goes to the whole ventricle and it causes the pumping of blood. This AV node is here because it can cause a significant delay of any high amount of atrial arrhythmia. So if in the atrium, there is a lot of arrhythmia started, like lots of multiple impulse, which is not supposed to be there, the AV node can cause delay of that. So a lot of these atrial arrhythmia will not travel to the ventricle. And in that way, your heart is designed to stop some form of arrhythmia just by its own. The problem in WPW syndrome is that it can bypass the AV node because there is an accessory pathway in this patient which causes the bypass of AV node, and any atrial arrhythmia can directly go to the ventricle. That's why it is risky. Now, obviously, there will be some rhythm or some electrical impulse will go to the AV node as part of the normal heart process, but most of it will go with this accessory pathway. Now, in case of management, if you give some medication which can cause more block of this AV node, that means if AV node cannot work properly, in that case, it will just get more and more worse. So what causes AV nodal block? So that's all the blockers like beta blocker, calcium channel blocker, even adenosine, digoxin. All of these common medications you can't use in WPW syndrome patients. The only medication can be used is any of the anti-arrhythmic medication. So if you look on these options, verapamil, adenosine, digoxin, all are not indicated in here. Or you can see these are contraindicated in this patient. So amiodarone is an anti-arrhythmic medication. That's what you can use in this patient. Patient is stable, so no need of DC cardioversion. Is this clear for everyone? The WPW syndrome? Good. A 65-year-old patient presents with lightheadedness and palpitation. The examination was clinically normal. He is on perindopril, L-toxin, verapamil, and anti-diabetic medication. ECG shows first-degree heart block. What is the next appropriate treatment? So you have got a patient who is symptomatic of lightheadedness, palpitation, and you have got some medication, but ECG showing heart block. Any heart block, the first thing that we look for is that if there is any medication which is causing it worse, and we stop that medication. So find out which medication from here. So increase L-troxin. L-troxin is actually a thyroxine, which is a thyroid medication. Stop verapamil, that's your rate limiting calcium channel blocker. Stop perindopril, no need to stop it because it has nothing to do with the heart rate. Add digoxin. We don't add digoxin because it can cause more block. Increase L-troxin. If you increase thyroxine, it will not have any issue in here. And why we are going to increase it? We don't even know the thyroid level in this patient. So we have to stop verapamil, which is already causing rate limiting as well, right? So this is actually one of the medication which can reduce your heart rate. So while a patient already having a heart block, if you give them any beta blocker, calcium channel blocker, that will make it worse. So stop those medication. Next, a child was treated with upper respiratory tract infection and treated for infective endocarditis. Blood culture was taken, treated with penicillin, but murmur still persists. What to do? Give antibiotic for 4 weeks with blood culture weekly. Echo, repeat blood culture, switch to meropenem. Now, this is an infective endocarditis, which you have treated, but it was not fully treated. Because if you have treated it, the murmur should not be there. So what it could be, there must be some of the vegetation is still left on the cardiac valve or endocardium. So how to actually find that out? The only way to find that out is doing an echocardiogram. So we say that if you have treated infective endocarditis, still there is a murmur, the likely chance there is some form of vegetations either on the valve or on the endocardium. Okay, so in such cases, only the echo will be able to diagnose it properly, nothing else. So infective endocarditis, we haven't discussed this one. So we say that in case of infective endocarditis patient usually gives you a history that they had maybe a rheumatic heart disease while they were child. They had a sore throat and then they developed rheumatic fever. Then they had a heart murmur. So that's rheumatic heart disease. Rheumatic heart disease patient, they are always advised that if they go for any kind of dental surgery or any kind of surgery, they should inform their doctor about it because they need antibiotic prophylaxis before going for this dental surgery. So let's say a patient went for a dental surgery, patient had rheumatic heart disease, did not inform the dentist. What happened? Because of no antibiotic prophylaxis, likely chance some bug has entered into the blood and the blood traveled into the heart, and that bug actually now deposited on the heart valve or endocardium, causing the infective endocarditis. Patient will present to you with fever, loss of weight, loss of appetite. They can have chest pain. They will have a lot of sign of infective endocarditis, especially they can get Osler nodes, genoelation, splinter hemorrhage. So we will discuss that in the class. They might have a murmur. They can have splenomegaly. If you do a urine test, the patient can have hematuria. So all of this lead you to think that this is an infective endocarditis case. Your next step is to do a blood culture, at least 3 sets of blood culture to confirm the diagnosis. And that's your initial investigation. Once you have taken the blood for culture, you have to start the patient with IV antibiotic, which is a broad spectrum IV antibiotic. And after that, to confirm the diagnosis, you have to do an echocardiogram. Okay, so that's usually the infective endocarditis. There are few other guidelines that which patient need antibiotic prophylaxis before they go for this kind of surgical procedure. So that's in your John Mutter. When we discuss infective endocarditis, likely chance we will come across that. Okay, let's move on. A pregnant woman at 36 weeks of gestation presents with dyspnea and orthopnea. X-ray shows bibasilar effusion and cardiomegaly. Examination has bibasilar crypts. What is your next appropriate investigation? First of all, tell me what you think about the diagnosis. 36 weeks old gestation, dyspnea, orthopnea, bibasilar crepitation, cardiomegaly. That should give you the diagnosis anyway. This is a heart failure case, guys. Why we are thinking about pulmonary embolism? Heart failure, right? So you have got dyspnea, orthopnea, you have got bibasilar crepitation, or even like if it is a bibasilar effusion, let's say pleural effusion, heart failure can cause bilateral pleural effusion, cardiomegaly, which only you will get in case of heart failure patient, and you have got bibasilar crypts. So why we are thinking peripartum cardiomyopathy, those kind of complex thing. This is a heart failure in a pregnant patient. What are you going to do next? ECG, echo, D-dimer, CTPA. First is always ECG. As we discussed that any kind of heart failure, ECG should be our first investigation. And if they ask what is your most appropriate investigation, then we would choose echocardiogram. Okay. You have got a patient who you inserted pacemaker. Now having difficulty in breathing with faint heart sound, saturation 96, hypotension, raised JVP. What is your investigation of choice? Tell me what is your diagnosis. So faint heart sound, hypotension, raised JVP. We're talking about a triad. This is Beck's triad, right? Very good. So it's likely to be a cardiac tamponade because muffled or faint heart sound, hypotension, raised JVP. That's cardiac tamponade. Okay. If it is a cardiac tamponade, what will be your investigational choice? X-ray, CTPA, ECG, echo. Only echo can diagnose this. So you have to go for urgent echocardiogram in this patient. See that if it's not very easy if you really don't understand the question. You might know Beck's triad, but if you can't remember or correlate, then you will never know. So it's all about understanding the theory and implement those during question solve. A hypertensive and a diabetic patient presents with history of numbness, nausea, and sweating. But this is a hypertensive and diabetic patient. Let's say it's a 50-year-old man. He developed dizziness while urinating. Pulse is irregular and ECG shows AF. What is the diagnosis? Myocardial infarction, micturition syncope, vasovagal syncope. That's right. So this is a patient who is 50, diabetic, hypertensive, and patient actually felt dizzy numb, nausea, sweating, and AF. Remember, what is the most common cause of AF? Myocardial infarction or ISD. So it's likely that we will always choose MI in this patient. So you guys actually got my idea that what we should think based on the symptom of a patient. A lot of candidates will think it as a micturition syncope. It's not like that. Just because during urination it happened doesn't mean that it has to be a micturition syncope. We always think it as a whole. If hypertensive, diabetic patient, sweaty, numb, that's more than enough to think about myocardial infarction. All right, so this will be our last question to discuss. So you've got an old woman brought after fall who is confused and on warfarin. You have got bruises on both thighs and buttock. Troponin is normal, but CK is very much elevated. What is your diagnosis? A lot of time this kind of question comes. So you've got a patient, like an elderly patient, had a fall and then was unconscious for 12 hours. And maybe a neighbor called the ambulance, and then paramedics found patient is lying on the floor. That is a classic scenario of rhabdomyolysis. Okay, so when patient lie down unconscious for such a long time, their muscle starts to break down, and when the muscle breaks down, the myoglobin is released from the muscle. Okay, and that myoglobin can cause a lot of effects. So especially that myoglobin can deposit into the kidney, causing kidney failure. You can also get hematuria, but that's actually myoglobinuria. So you get a dark reddish brown urine. Okay, so in such cases, CK will be elevated. The complication of rhabdomyolysis is that patient can get severely dehydrated. So hypovolemia, hyperkalemia, hypocalcemia, even cardiac arrest. Kidney damage and acute kidney failure is also one of the chance. So if you have got a patient who has got such a history, like lying on the floor, unconscious, and then you can see some bruise on the muscle, and you did a CK, which is very elevated, that's more than enough for you to diagnose rhabdomyolysis. What will be your treatment in this patient? That means the first treatment. Hydration, Dr. Priya, very good. So IV fluid is your first management that you do, because it can cause severe dehydration, and also it can protect the kidney if you can hydrate the patient well. Okay, so that's all about today's class, guys. I hope you learned something from this 2-week session. I hope that the things that actually you want to see, that are you actually happy to join the course or not, you should have a decision by now, or at least you know how the exam is going to happen. At least you should have an idea that, like, what I should do to prepare for this exam. The AMC MCQ exam is not very hard if you know how to prepare. If you waste your time by going through a lot of stuff, you will find out that even after 8 to 10 months, you have already seen a lot of people who is passing, and then you fail the exam. So I always say that you have to be at least 70% confident to go for exam. Okay, and before going for exam, if you are a part of the course, then obviously I would always suggest to go for the mock exam. So at least the 150 mock exam, which is just same like AMC. If you pass those mock exam, likely chance you will pass the real exam as well. So that's how we prepare you for this exam. Now, I will allow any of you to unmute yourself and ask any questions that you want. If you are a part of the course already, then wait for the orientation class, because we will discuss everything about the portal and exam. If any of you wants to know about the course or any particular question you have, just feel free to ask. And as we discussed in our some of the trial classes, that what will be the course actually, what are the main thing the course is going to do, right? So let me just go through that course details with you so that any question that you have that is well answered. So as we already said that the new batch has already started. You are actually doing the part of the course, but this is free for everyone so that everyone gets an idea about the course. The Facebook group link is given and all of you should be in Facebook group. That's how you have joined the class anyway. If you want to go through our website, so go to the firstaidamc.com and then you should be able to see all the details there as well. So we actually do everything that you need for the exam, which includes full theory, 5-year recent sample question discussion, and you must be already aware that how we take our question solve classes. Software-based exam, which has a lot of subjective, month-wise, and full mock test. QBank, you get the access to the note until you pass. Recording of every class with extended access even after finishing the course. You can also claim CPD hours from my class if you are a part of RACGP or ACRAM. The course fee is $499. Duration 5 months. Class is usually for 3 days a week, sometimes 4 days. Currently, we are doing it as Saturday, Sunday, and Tuesday. Class time is 8 to 10, sometimes up to 10:30. Class is always on Zoom, never on Facebook. So from the next time, if any of you are doing on Facebook and you have joined the course, please make sure that you join the Zoom because there will be no Facebook live session anymore. Okay, so that's pretty much most of the thing that we do. We also discussed where we do the complete theory. We do the theory-based question discussion, just like we did today. And then after finishing everything, you can also go for a theory practice test. So there is a cardiology mock test in your portal. After you have finished cardiology, you can go and do that exam and see how you are doing. Also 5-year recent sample question discussion. And also like there's a huge amount of questions already in the portal with videos of discussion as well. So if any of you can finish 6 months to 1 year even, that's more than enough. Recent sample question mock test is available. Software-based mock test, there are a number of mock tests that we always talk about. There is extra classes on ECG, CT scan, X-ray and other imaging, and also stat, ethics, fundoscopy, and ABG. These are important extra things that come in exam, which will be discussed throughout the course. Okay, so that's more or less about the course. I hope you enjoyed the 2-week sessions. I hope all of you pass your exam as soon as possible, and then you go to your next step. Either you go for the job or you start your AMC part 2. Okay, but throughout your course, First Aid AMC usually helps a lot of IMGs over long time. And if we go back, there are students who are working in Australia at the moment who have passed both MCQ and clinical from here. So when you start joining with us, that's how your dream is going to come true, and likely chance that everything that we are going through with you, every guideline that we are showing you, that will be more than enough for having your dream to come true. Okay, but you have to do your own part. You have to do hard work. This is not a very easy exam, and there is no hide and seek that just like someone is saying, if I just do a QBank, I'm going to pass the exam. If I just do 6-month question, I'm going to pass the exam. It's very unlikely that's the case. They also haven't done that, but when they write a review or feedback, they actually just say that so that other people get confused. And I always say that please don't think in that way. Please don't listen to people who misdirect you. And having a guideline on your back is important, because none of you are working in Australia, and we are working in here. There is no one who knows better guideline than us who are working here already. Okay, so you get all the recent guidelines from us, even though sometimes JM might have like not the updated guideline, but most of us already know what we are following in here. So we will be always be able to help you in that regard as well. Okay, any questions? So for those of you who has already joined the course, the orientation class will be the next one, which is on Tuesday. So just in 2 days, that will be your next class, and a full class schedule will be given in your Facebook group. So just have a look on that one. And Dr. Afrin, once payment is done, just send an email or just an inbox that you have done the payment, what to do next. So then we will tell you what to do. All right, everyone, that's it for tonight. Thank you, everyone. Take care. And we're going to start your 5 months MCQ course in the full rhythm from now onwards. Hopefully, you will enjoy. Thank you all. Have a good night. Take care. Bye.